Welcome back to the Deep Dive. Today, we are doing something a little different, something very specific and frankly high stakes. We are simulating a high-intensity revision session. I'm going to be the student, the postgraduate resident, and you are going to be my senior MD anesthesia faculty.
That's right. And we are specifically targeting the Gujarat University MD anesthesiology exams. So this isn't just a casual chat about medicine.
Yeah.
This is about survival in the exam hall. We are talking about pain relief in pediatric patients and pediatric regional anesthesia.
And from looking at this stack of textbooks and papers we have here, I see Miller, Morgan and Mikhail, Stolting, and those question banks. This is a massive topic.
It is huge. And it is a guaranteed section. You are looking at a potential 10 to 20 mark long question in your theory paper.
Oh.
It is a favorite in the Viva Voce, and it's a high-stakes station in the OSCE.
Okay.
If you mess up pediatric safety in an exam, you don't just lose marks, you fail the station.
Right.
So the mission today is to move you beyond basic definitions. We need examiner-approved keywords, precise safety protocols, and the physiological nuances that, differentiate a neonate from just a small adult.
Okay, I am ready. I've got my pen out. Let's start with Part A, Introduction and Exam Framing. If I get a long question, say, discuss the anatomy, physiology, and pharmacology of pediatric pain, where do I even begin?
You begin with the paradigm shift. You have to show the examiner you understand the history. Until, the mid-'80s, there was this terrifying, erroneous belief that neonates didn't feel pain.
Right, because of incomplete myelination. That was the theory.
Exactly. The old dogma was that because the nerves weren't fully myelinated, the signal wouldn't get through. But we know from Miller's anesthesia and Stolting that this is completely false.
Okay.
You need to state clearly, neural pathways for nociception are present by 23 to 26 weeks gestation.
So a premature baby absolutely feels pain. There's no question.
Absolutely. And your role as an anesthesiologist isn't just numbing the patient. The IASP, the International Association for the Study of Pain, their definition involves both sensory and emotional experiences.
Right.
But here's the catch for pediatrics. Neonates cannot self-report. So for the exam, you must emphasize that the inability to communicate pain does not negate the existence of pain.
That's a really strong opening statement for a theory answer.
It is. It frames the entire answer around preventing the consequences of pain, not just the sensation. The examiners look for 3 types of questions here.
Okay.
The long question, which covers everything. Then short notes, which might be fetal pain perception or non-opioid analgesia.
Got it.
And the Viva, which is where they will grill you on safety, on toxicity calculations, and on anatomical landmarks.
Okay, let's get into the weeds then. Part B, Pediatric Pain Physiology. You mentioned the pathways are there early, but they aren't exactly the same as in adults, right?
Not at all, and this is where you pick up serious marks. You need to talk about the ontogeny of nociception. Write that phrase down.
Ontogeny of nociception.
Got it. So peripheral receptors appear by 20 weeks. The thalamocortical connections, which you need for actual consciousness and perception of pain, are functional by 24 to 30 weeks.
Okay.
But here is the critical exam point, the imbalance.
The imbalance. What do you mean by that?
Think of it like a car. The excitatory pathways, the accelerator develop before the inhibitory pathways, which are the brakes.
Ah, I see.
Neonates have these large receptor fields. They have a really high concentration of substance P receptors.
Substance P is the main pain transmitter, right?
Correct. So they have a lot of the transmitter, and their receptor fields are huge, meaning a little prick on the heel might be much more widely, much more intensely.
Okay.
But the crucial part is the descending inhibition. In adults, the brain sends signals down the spinal cord to dampen pain signals, to sort of turn down the volume.
Right, the gate control theory.
Part of that, yes.
Yeah.
That whole system is immature at birth.
So they have a really sensitive accelerator and basically no brakes.
Exactly. That is the key word the examiner wants to hear. Immature descending inhibitory control. This makes neonates more sensitive to pain than adults, not less. If you say they're less sensitive, you fail. It's that simple.
Understood. Crystal clear.
Right.
Now, moving to Section 3, consequences of poor pain control. Why does this matter so much physiologically? This seems like an exam favorite.
It is an absolute favorite. You need to be able to list the stress response. Uncontrolled pain triggers a massive, and I mean massive, release of catecholamines, cortisol, glucagon, and aldosterone.
And clinically, that looks like what? Tachycardia and hypertension, the usual signs.
Yes, but you have to dig deeper for the exam. It causes hyperglycemia. It causes protein catabolism, a negative nitrogen balance.
Indeed.
It means the body is breaking down its own muscle and protein that impairs wound healing. In a fragile neonate, this is a complete disaster.
Yeah.
And then there's the concept of wind-up and neuroplasticity.
Wind up. Like a toy. What does that mean?
Like a nervous system that gets permanently rewired. The immature brain is highly, highly plastic. If a baby experiences repetitive pain like, say, frequent heel pricks for blood tests or an unanesthetized circumcision, it can permanently alter the spinal architecture.
That sounds permanent.
It can be. There was a famous study in all our sources where they looked at infants who had circumcision without any anesthesia. Months later, when those same babies got their routine vaccinations, they showed a significantly increased pain response. I mean, they cried more, their heart rates went higher compared to the uncircumcised peers.
Wow. So the early pain actually sensitized them to future pain.
Yes. It essentially rewires them to be hyperalgesic. It lowers their pain threshold for life. And don't forget the risk of IVH.
Intraventricular hemorrhage.
Exactly. In preterm infants, pain causes wild fluctuations in blood pressure. Their cerebral vessels are as fragile as wet tissue paper. If their BP spikes because of pain, they can bleed directly into the brain.
That is a massive morbidity. Okay, I see now why this is so high stakes. Let's move to Part C, pain assessment. If they can't tell us they hurt, how on earth do we measure it?
This is Section 4, and it's very high yield for short notes. The gold standard is always self-report, but you can only get that if the child can talk and understand. For everyone else, we use tools.
Okay.
And you need to know which tool fits which age group.
Let's start with the smallest. Neonates. What do we use?
For neonates, it's purely observational. You have the CRIES scale, C-R-I-E-S. It's an acronym.
Okay, break that down for me.
Crying requires oxygen. That's a physiological sign of distress. Increased vital signs, expression on their face, and sleeplessness. It's specific to post-op pain.
Okay, cries. What else?
Then there is the PIPP, the premature infant pain profile. This one is unique because it actually includes gestational age as one of the variables.
That makes a lot of sense given everything you just said about their development.
It does. And there's also NIPS, the neonatal infant pain scale. You should know the names of at least two.
Cries and PPP. Got it. What about toddlers? The ones who are running around but can't really articulate, I have 7 out of 10 pain.
The examiners love the FLACC scale for this group. FLACC. Face, legs, activity, cry, consolability.
I've seen that one used. Legs is usually about whether they kicking or drawn up tight, right?
Exactly. A relaxed child has relaxed legs. A child in pain often draws them up towards their chest or kicks restlessly. And consolability is key.
Can you distract them?
Right. Can you soothe them? If they are totally inconsolable, that's a high score. That's a big red flag for severe pain.
And for the older kids who can communicate a bit.
Around age 3 or 4, you can introduce the Wong-Baker Faces scale. You know the one, the 6 cartoon faces ranging from a big smile to a full-on crying face?
The child just points to the face that matches how they feel.
Simple and effective. And then the visual analog scale, the VAS.
The line from 0 to 10.
That's for children older than about 7, who can understand the concept of numbers and ratios. 0 is no pain. 10 is the worst pain you can imagine.
Now, Section 5 here mentions challenges in pain assessment. I feel a trap coming. Is there a trap here?
Huge trap. It's the vitals trap. In the ICU, or even in the OT, you might see a child with tachycardia or hypertension. Your first instinct is pain. Do not assume it is definitely pain.
But you just said pain causes a catecholamine release, which raises the heart rate.
It does. But so does hypovolemia, so does anxiety or fear, so does a full bladder or just being cold. If you tell an examiner the heart rate is 180, so I will give fentanyl, they will fail you. You have to say, the heart rate is elevated. I will first assess the whole clinical context, rule out other causes, and use a validated pain scale before administering an opioid.
Assess the context first, but what about in a paralyzed, ventilated neonate?
Now that's the exception. In that case, physiological changes might be the only clue you have, so you have to rely on them more, but still with caution.
What about the intubated older child?
You can use the comfort scale or the BPS, the behavioral pain scale. You have to look at things like compliance with the ventilator. Are they fighting the tube? Are they grimacing? That's often a sign of pain or distress.
Okay, let's move to Part D, pharmacological pain relief. This is the real bread and butter. Section 6, systemic analgesics.
We start with the absolute backbone, paracetamol or acetaminophen.
It seems so basic, but I bet there are exam specifics I need to know.
There are. Dosing is a standard Viva question. You must say clearly 10 to 15 milligrams per kilogram, IV or oral.
What about rectal? We use suppositories all the time on the wards.
We do, but you must tell the examiner that rectal absorption is erratic and unpredictable. For the exam, you can mention that a loading dose is often required, maybe 20 to 30 milligauss, followed by maintenance doses. But stick to the Epidural dose of 10-15 milligrams as your primary answer.
And safety, what's the max dose?
The maximum daily dose is 60 milligrams in neonates. Older children can tolerate a bit more, up to 90 milligrams, but liver toxicity is the absolute limit. You must respect it.
Right. Moving on to NSAIDs. Ibuprofen, diclofenac, ketorolac.
These are absolutely crucial for opioid sparing. That's the key word.
Opioid sparing.
If you use NSAIDs, you use fewer opioids, which means less nausea, less itching, and most importantly, less respiratory depression.
Yeah.
But you must list the contraindications.
Okay, so renal impairment is the big
Yes. Also, asthma, dehydration, any bleeding diathesis, and specifically for neonates, ductus-dependent cardiac lesions.
Can you explain that again, the ductus part?
Sure. NSAIDs inhibit prostaglandins. Prostaglandins are what keep the ductus arteriosus open in a newborn. Some babies have congenital heart defects where they need that duct to stay open for blood to get to their lungs or body. If you give them an NSAID,
You close the duct?
you close the duct and you can cause acute cardiac collapse. It's a fatal error.
That is a vital safety point. Okay, Section 7, opioids. The outline says this is exam gold.
It is, because neonates are exquisitely sensitive to opioids, and you need to explain why to the examiner. There are two main reasons. One, the immature blood-brain barrier. It's leaky. More of the drug gets into the brain compared to an adult.
Right.
Two, decreased clearance. Their liver enzymes, especially the CYP pathways, aren't fully working yet. They can't break the drug down efficiently.
So the drug hits harder and it stays in their system longer.
Exactly. Morphine is the classic standard, but you have to watch for its active metabolites, like morphine 6-glucuronide, which can accumulate if the kidneys aren't working well.
Okay.
Fentanyl is often preferred in the OT because it provides more hemodynamic stability.
What about codeine? I feel like I've seen warnings about that recently.
This is a massive Viva trap. Codeine is a prodrug. It doesn't do anything on its own. It has to be metabolized by an enzyme called CYP2D6 into morphine to actually work.
And genetics plays a role in that enzyme.
A huge role. Some children are ultra-rapid metabolizers. They have genetic polymorphisms that cause them to convert codeine to morphine incredibly fast and in large amounts.
So a normal dose could be an overdose for them.
Exactly. There have been documented cases of children dying from fatal respiratory depression after a routine dose of codeine, especially after a tonsillectomy. Many guidelines now restrict or outright ban codeine in children. If an examiner asks, what do you prescribe for home analgesia? Do not say codeine.
Good tip. Wow. Okay, Section 8 is multimodal analgesia.
This is the standard of care. You should say that exact phrase.
The standard of care.
You never rely on just one thing. It's paracetamol plus S and NSAID plus a local anesthetic block, plus the small dose of an opioid if needed. The synergy allows you to lower the dose of each individual drug, which minimizes the side effects of each.
So you get better pain relief with fewer side effects.
That's the entire goal. Better pain relief, less nausea, less respiratory depression.
Okay, now we're getting to the heavy machinery.
Yeah.
Part E, Pediatric Regional Anesthesia. This is Section 9.
This is absolutely essential. First principle, the awake versus asleep debate. In adults, we often want them awake for a block so they can report paresthesia or pain on injection, which warns us of a potential nerve injury.
But we don't do that in kids, do we?
No. Imagine trying to hold a squirming, terrified 3-year-old perfectly still for a spinal needle. It's traumatic and it's dangerous.
Yeah, impossible.
The standard practice, which is supported by huge databases like the PRAN database, that's the Pediatric Regional Anesthesia Network, is to perform these blocks after the induction of general anesthesia.
So they are completely asleep.
Yes. The safety argument is that the risk of a moving child causing needle trauma to themselves or something else is far higher than the theoretical risk of masking a nerve injury symptom.
Okay, that makes sense. Section 10 covers anatomical and physiological considerations. How is a child's anatomy different when it comes to doing blocks?
Several really important ways. First, myelination. We talked about this before. The nerves are incompletely myelinated. This means local anesthetics can penetrate the nerve fiber much more easily.
So you often need lower concentrations of the drug.
Exactly. Second, they have very loose connective tissue. The fascial sheaths that surround nerve bundles are looser, so the drug spreads much further and faster than it does in an adult.
Okay. And pharmacokinetics. You mentioned this was a high-yield Viva point.
Extremely high yield. It comes down to protein binding. Neonates have very low levels of a specific protein called alpha-1 acid glycoprotein, or AG.
And why does AG matter so much?
Local anesthetics like bupivacaine love to bind to AG. In adults, most of the drug in the bloodstream is bound to this protein, so it's inactive. It's a buffer. In neonates, because their AG levels are low, there is much more free, unbound drug circulating in their blood.
And more free drug means a much higher risk of toxicity.
Gingo. Add to that a high cardiac output, which sweeps the drug away from the injection site into the circulation faster, and you have a perfect storm for toxicity. Last local anesthetic systemic toxicity is a major, major concern.
Let's talk about the blocks themselves then. Sections 11 and 12. Caudal anesthesia. The outline says this is very high yield.
Caudal is the absolute workhorse of pediatric regional anesthesia. If you are asked to describe just one block in detail, this is the one you need to know inside and out.
And it's used for what kinds of surgery?
Almost everything below the umbilicus. Inguinal hernias, hypospadias repair, orchidopexy, clubfoot surgery. It's incredibly versatile.
Walk me through the anatomy for the exam.
You need to know the landmarks cold. You feel for the sacral cornua, which are two little bumps at the base of the sacrum. They form an equilateral triangle with the posterior superior iliac spines, the PSIS. You're aiming for the sacral hiatus, which is the space between the cornua.
And what's the danger zone? The dural sac.
This is the most important anatomical difference. In an adult, the dural sac ends at the S2 vertebral level. In a neonate, it ends much lower down at S3.
So it's closer to where you're putting the needle.
Much closer.
Yeah.
The distance between the sacral hiatus and the dura is very short. The risk of an accidental dural puncture is significantly higher than in an adult.
What about the spinal cord itself?
Also different. The conus medullaris, the end of the spinal cord, terminates at L3 in a neonate versus L1 in an adult. So you have to be very careful with lumbar epidurals or spinals. But for a caudal, you're entering way down at the sacral hiatus, so you're well below the cord.
Okay. How do you calculate the volume? I see Armitage formula written here.
You must memorize this. The Armitage formula using 0.25% bupivacaine or ropivacaine is your guide. 0.5 millikilograms will give you a lumbosacral level block, which is good for things like circumcisions.
Okay.
1.0 millikilogram gets you up to a thoracolumbar level, which is what you need for inguinal hernias.
Then higher.
1.25 millikilogram can get you up to a mid-thoracic level, but the risk of complications increases. Most people stick to 1 millimilkilogram as a practical maximum.
So for a 10-kilogram kid having a hernia repair...
You want thoracolumbar coverage, so that's 1 millikilogram. You'd use 10 milligrams of solution.
That seems like a lot of volume for a small child.
It is, but remember, the concentration is usually dilute, like 0.125% or 0.25%. And you must always, always cross-check the total milligram dose against the maximum toxic dose. For bupivacaine, it's generally quoted as 2 to 2.5 milligrams per kilogram. You calculate your volume, then calculate the total milligram dose, then divide by the child's weight to make sure you are safe, every single time.
Part F, Safety and Complications. Section 13 is Alès-Tyleri local anesthetic systemic toxicity.
We touched on this. Low protein binding, high cardiac output, immature liver metabolism. It's the perfect storm for toxicity.
What are the signs? In an adult, they get tinnitus or dizziness, but you won't see that in an anesthetized child.
No. You will see cardiovascular signs. You'll see ECG changes, tachycardia first, then maybe a widened QRS complex, arrhythmias, or T-wave elevation, eventually bradycardia and cardiac arrest.
And the treatment?
Lipid emulsion therapy. Intralipid 20%. It acts as a lipid sink to literally soak up the lipophilic local anesthetic drug from the plasma and from the tissues.
And every operating theater doing these blocks must have it immediately available.
It is a mandatory piece of emergency equipment, non-negotiable.
Section 14 mentions compartment syndrome masking. This sounds controversial.
It is. The old fear was that if you do a perfect nerve block for, say, a tibial fracture repair, you will mask the excruciating pain of a developing compartment syndrome.
And that could lead to a lost limb.
That was the fear. The modern view, however, is that a good block should not completely mask the severe, unrelenting breakthrough pain of ischemia, but you must be vigilant. For the exam, you should acknowledge the controversy but emphasize that withholding effective pain relief out of fear is not the ethical or appropriate solution.
Okay. Moving to Part G, Post-Operative Pain Management, Section 15.
Right, the block will wear off. What's next? We have NCA and PCA. Nurse-controlled analgesia is for the little ones who can't manage a button themselves. It's usually a background infusion plus a bolus button that the nurse can press based on a pain score.
And PCA.
Patient-controlled analgesia, that's for older kids, usually older than 6 or 7, who can understand the concept of, if it hurts, push the button for more medicine.
Section 16 highlights special populations. What about ICU patients?
Here you have to worry about withdrawal. If a child has been sedated and on opioids for days or weeks in the ICU, you can't just stop them. They'll get iatrogenic abstinence syndrome.
So you have to wean them off slowly.
Exactly. You need a written weaning protocol.
And what about patients with burns?
Burns, patients have massive opioid tolerance because of their chronic severe pain. They need huge doses. And ketamine is your best friend here for things like dressing changes. It provides dissociative anesthesia. They are awake, but they are completely disconnected from the painful stimulus.
Okay, we are in the home stretch now. Part H, exam integration,
Yeah.
Section 17. Comparison tables.
For your theory paper, you need to be able to draw a simple table comparing adult versus pediatric regional anesthesia. It's easy marks.
So what are the key points?
Conesus level, L1 in an adult versus L3 in a neonate. Dural sac level, S2 in an adult versus S3 in a neonate.
Got it.
Sympathetic blockade. This is a really interesting one. Adults get significant hypotension when you do a spinal or a high epidural because their blood pools in their leads.
Right, venodilation.
Young children, under about 8, rarely get significant hypotension. Their venous capacitance vessels aren't as compliant. They don't pool blood as effectively. Their cardiovascular system is more dependent on heart rate.
That is a brilliant fact for the Viva. Why didn't the blood pressure drop after the spinal?
Exactly. Also, Section 18, common Viva traps. You need to be ready for these.
Give me.
Trap 1. Why don't we use epinephrine in a penile block?
Because it's an end artery supply. You risk ischemic necrosis of the penis.
Perfect. Trap 2. Can you perform a spinal anesthetic in a neonate?
Yes. Specifically for ex-premature infants to avoid the risk of postoperative apnea that's associated with general anesthesia.
Excellent. You know that ex-preemies are prone to stopping breathing after a GA.
Correct. A spinal without heavy sedation can prevent that risk entirely, but it is technically very difficult to perform.
Very good. Finally, Section 19. Diagrams. In the theory exam, don't just write a wall of text. Draw. Draw the pain pathway. Draw the sacral anatomy showing the hiatus, the cornua, and the level of the dural sac. Draw the WHO analgesic ladder, modified for kids. It breaks up the text, and it shows the examiner you can visualize these concepts.
So to summarize Part H and really this whole session.
The elevator pitch for the exam is this. Pediatric pain management is all about anticipating physiological immaturity, immature metabolism, excretion, and neuroinhibition. It requires a multimodal approach as the standard of care. Safety is absolutely paramount, so you calculate your mg/kbd dose every single time, and the caudal block is your best friend.
Fantastic. That feels like a really solid foundation.
It is. But remember, the exam isn't just about regurgitating facts, it's about demonstrating your commitment to safety. If you sound safe, you pass.
Okay, let's unpack some of these sections in even more detail then. I want to go back to the physiology in Part B.
Yeah.
You mentioned the wind-up phenomenon. Can we go deeper there? I feel like that's a concept I understand superficially,
Right.
but couldn't explain well for, say, 5 marks.
Sure. Let's drill down on that. Wind-up is a form of central sensitization, and it's all about the NMDA receptors in the dorsal horn of the spinal cord.
Okay, the NMDA receptors.
When you have repetitive stimulation of C fibers, those are the slow, dull, aching pain fibers, it causes this cumulative depolarization of the second-order neuron.
So the neuron gets more and more excited, and the threshold for it to fire drops.
Exactly. The magnesium plug that normally sits inside and blocks the NMDA receptor channel gets kicked out. This allows a flood of calcium to rush into the cell. This calcium influx triggers a whole cascade of intracellular events that makes that neuron hyperexcitable.
And the result of that is?
The result is that a stimulus that was previously non-painful can now be perceived as painful. That's allodynia. And a stimulus that was mildly painful now becomes excruciating. That's hyperalgesia.
And in neonates, this is even worse.
Yes, for a couple of reasons. Remember, the receptor fields are larger and they overlap more. So a single prick on the heel activates a much larger pool of neurons in the spinal cord to begin with.
Okay.
And critically, they lack that descending inhibitory track. The serotonin and norepinephrine pathways from the brainstem aren't fully functional yet to shut this gate, to stop the windup.
So the windup just spins out of control much faster.
Precisely. And that's why pharmacologically, we sometimes use drugs like ketamine.
Because ketamine is an NMDA antagonist.
It is. It directly blocks that specific receptor involved in the wind-up phenomenon. It prevents the whole cascade from starting.
That connects the pharmacology to the physiology perfectly. That's brilliant.
Also, regarding the stress response, you need to mention the metabolic cost. A neonate has extremely limited glycogen stores in their liver. If pain triggers a massive catecholamine surge, they burn through that tiny store of glycogen very, very quickly. Hypoglycemia in a neonate can cause seizures and permanent brain damage. So pain relief isn't just about kindness, it's about metabolic stability.
I love that. Pain relief as metabolic resuscitation.
I like that phrasing. Use that in your exam.
Let's jump back to section 11, the regional blocks. We talked about the caudal. What about the tape block, the transversus abdominis plane block? That seems to be very trendy right now.
It is, and it's definitely fair game for a modern exam. You should know it. It's a peripheral field block. You're not going near the spine. You are blocking the nerves, the thoracolumbar nerves that run in the plane between the internal oblique and the transversus abdominis muscles.
Is it used for the same things as a caudal block?
Similar, yes. Usually for abdominal surgeries where a simple caudal might not reach high enough, or when you want to specifically avoid any neuraxial complications. It's great for appendectomies, umbilical hernias, or for the pain from laparoscopic port sites.
And it's almost always ultrasound guided now, I assume.
100%. For the exam, you'd describe placing a high-frequency linear probe in the mid-axillary line between the ribs and the iliac crest. You see the 3 distinct muscle layers: external oblique, internal oblique, transversus abdominis.
The 3 stripes.
The 3 stripes, yes. And you inject the local anesthetic in the fascial plane between the inner 2 layers. It spreads like a sheet to block the nerves from about T10 to L1.
Is it safer than a caudal block?
It completely avoids the risk of dural puncture, epidural hematoma, and the urinary retention that you can get with a caudal. But it still has a significant risk of AS because that abdominal muscle plane is very vascular. Absorption can be surprisingly quick.
Let's talk about the ilioinguinal and iliohypogastric nerve block.
The classic hernia block. You can do this by landmarks or with ultrasound. The landmark technique is done medial to the ASIS, the anterior superior iliac spine. It's a fascial click technique. You use a blunt needle, and you feel a distinct pop as you pass through the external oblique aponeurosis.
Is it 1 pop or 2? I always get confused.
Usually just 1 distinct pop to get into the plane above the internal oblique. But you have to be very careful not to go too deep and hit the bowel. That's the major complication you need to mention: bowel perforation. It's rare, but it is possible.
What about penile blocks? You mentioned the epinephrine trap.
Yes, this is for circumcision. You're blocking the dorsal nerves of the penis. You have 2 main techniques: the ring block, which is just a subcutaneous ring of local anesthetic at the base of the penis, or the more specific dorsal penile nerve block, where you inject deep to buccal fascia at the 10 and 2 o'clock positions at the base.
And which one is better?
The dorsal nerve block is probably more effective and provides a denser block, but it has a slightly higher risk of causing a hematoma if you hit the dorsal vessels. The ring block is easier but can cause more edema.
And the golden rule?
The golden rule for both: never use epinephrine, and never use an excessive volume that could act like a tourniquet and compromise blood supply.
Got it. Now let's look at Part G again. Postoperative pain strategies. Specifically, the transition from IV to oral analgesia.
This is a very practical management question, they might ask. You don't want to keep a child in the hospital just because they need IV analgesia. You need a good bridging strategy.
So you'd start the oral medications before you stop the IV ones.
Exactly. You give the first oral dose while the IV infusion or the regional block is still working effectively. Don't wait for the pain to return to a 10 out of 10. This is a form of preemptive analgesia, but applied to the recovery phase. You stay ahead of the pain.
What about the parents' role in this?
A huge part of the equation. You must educate the parents before discharge. They are often fearful of addiction or side effects, and they will underdose their kids at home. You need to explain clearly that good pain control speeds up recovery, encourages mobility, and helps the child start eating and drinking again.
Section 16 mentions sickle cell disease. That feels like a very specific exam curveball.
It is, but a very important one. Children with sickle cell disease are often frequent flyers. They have these vaso-occlusive crises. This is ischemic pain. It's literally bone infarction. It is 10 out of 10 excruciating pain.
And they often have a high tolerance to opioids from previous crises.
Yes, they are often on chronic opioid therapy at home. If they come in for surgery, say a cholecystectomy or a splenectomy, their normal baseline dose won't even touch the sides of the acute surgical pain.
So what's the plan?
You must continue their baseline opioid requirement, ANA, add the dose required for the acute surgical pain on top of that.
And importantly, do not label them as drug-seeking.
Never. That is a major ethical failing and an exam failing statement. They have genuine severe pathology. Also, your entire anesthetic management must be geared towards preventing factors that trigger sickling: hypoxia, hypothermia, dehydration, and acidosis.
Let's practice a Viva scenario. I'll be the candidate, you be the examiner.
All right. Candidate, I have a 4-year-old child for the repair of an inguinal hernia. Please outline your plan for postoperative pain relief.
Okay. My plan would be a multimodal one. Preoperatively, if possible, I would give a dose of oral paracetamol, 15 milligrams per kilogram. Intraoperatively, after the induction of general anesthesia, I would perform a caudal epidural block using 0.25% bupivacaine.
Stop right there. How much volume would you use? The child is 4 years old. Let's say they weigh 16 kilograms.
For an inguinal hernia repair, I would need to achieve a thoracolumbar level of block using the Armitage formula. That is 1 milliliter per kilogram. So for a 16-kilogram child, I would use 60 milligrams.
16 milliliters of 0.25% bupivacaine. Now calculate the dose in milligrams.
Okay, 0.25% is 2.5 milligrams per milliliter. So 60 times 2.5, that is 40 milligrams of bupivacaine.
And the child's weight is 16 kilograms. What is the dose per kilogram?
40 milligrams divided by 16 kilograms is 2.5 milligrams per kilogram.
Is that safe?
It is right at the upper limit of the maximum safe dose, which is generally accepted as 2 to 2.5 milligrams per kilogram.
So would you proceed with that dose?
Given that it's right at the limit, a safer approach would be to reduce the concentration to 0.2% or 0.125%. This would allow me to use the same volume needed for the spread, but it would reduce the total milligram dose and provide a wider safety margin against systemic toxicity.
Good. That's a much safer answer for the exam. You preserve the volume for spread, but you reduce the toxic load. What else would you add to your multimodal plan?
I would also administer an NSAID, such as a diclofenac suppository, provided there were no contraindications like asthma or renal dysfunction. And postoperatively, I would ensure regular paracetamol is prescribed.
Good. And what if the block fails or is patchy?
In that case, I would use small titrated doses of an IV opioid like fentanyl in the recovery room, and then transition to oral analgesia for the ward and for discharge, such as oral morphine or ibuprofen. I would not use codeine.
You caught yourself. Very good. Never say codeine.
That was stressful even in a role play.
That's the point. You have to be able to do that math live, under pressure. Practice your conversions. Remember, 1% is 10 milligimolar, 0.5% is 5 milligimolar, 0.25% is 2.5 milligimolar, 0.125% is 1.25 milligimolar. Drill it until it's automatic.
We've covered so much. I think my brain is full, but in a good way.
We've covered the core physiology, that critical imbalance. We've covered assessment using the right scale for the right age. We've covered pharmacology, the multimodal standard of care. We've hit regional hard, especially the caudal block, the anatomy, the doses, and the safety. And we've covered the exam strategy.
Any final provocative thought for the listener?
Yeah.
Something to take away that isn't in the standard textbooks yet, maybe?
Here is one. We talked about pharmacogenomics with codeine and the CYP2D6 enzyme. The future isn't just banning codeine. It's moving towards precision analgesia.
What do you mean by that?
Imagine a world where before surgery, we do a rapid cheek swab on the neonate in the pre-op bay. We get a quick readout of their key CYP enzymes, their mu-opioid receptor sensitivity, maybe their COMT genotype, which affects pain perception.
Well, you wouldn't just guess a standard dose.
Exactly. We wouldn't just guess 0.1 millipicogram of morphine for everyone. We would dose it precisely for that individual child's genetic profile. We could eliminate so much of the trial and error, the underdosing and the overdosing that we currently struggle with. That is coming.
That would be a complete game changer. No more unexpected overdoses, no more children in agony because they're a poor metabolizer of a drug.
Until then, we rely on what we've discussed today. Constant vigilance, wide safety margins, and a robust multimodal therapy plan.
And practicing drawing the sacrum.
Definitely. Go practice drawing the sacral hiatus right now. Put your pen to paper.
Thank you. This has been a true deep dive. To our listener, the student, good luck with the Gujarat University exams. You have got this. Focus on the physiology, prioritize safety above all else, and watch out for those Viva traps.
Stay safe, keep learning, and be a fierce advocate for your small patients.
See you next time on The Deep Dive.